Hello and welcome to the second episode of Discover Series 4 of online education sessions brought to you by Salts Healthcare. If you have been unable to watch the first episode where we explored why specific dietary changes are needed to reduce the risk of stoma-related complications or perhaps necessary to alter the stoma function, don't worry, it's not too late. This episode, along with all the others as part of this series and all the other Discover series, can be accessed via the Salts Healthcare website. In this episode, we'll be hearing from Melanie Baker again. This time, she will be delving even deeper into the challenging issue of maintaining adequate and fluid electrolyte support for those patients experiencing a high output stoma. As stoma care nurses, most of us are used to managing those practical challenges posed to us by patients experiencing high output stomas, trying to ensure we are able to achieve a good wear time for our patients with minimal leakage and no sore skin. We are fortunate to have choice when it comes to the most suitable products to suit our patients' clinical and individual needs. But when it comes to the challenge of meeting the nutritional and fluid needs of patients with stomal losses reaching many litres within a 24-hour period, it is fundamental that we join forces and work collaboratively with our allied health colleagues to ensure patients receive the best possible care and the optimal advice.
Thank you to Salts Healthcare for asking me to present to you today. In this presentation, I'm going to talk about the management of high output stomas. I'm going to focus on fluid and electrolyte management though. I'm not really going to cover off other aspects such as medication management. Okay, so when we talk about high output stoma, the first thing we need to do is decide when a stoma is a high output stoma. And this in itself is quite problematic because opinion varies. It varies in the literature, and it also probably varies in terms of who you speak to, in terms of which health professional group. So as I work in intestinal failure and I work with patients that have to go home on parenteral nutrition, so we often will see that patients are running into problems and needing intravenous support if their outputs are more than sort of 2 litres a day. So we will often use that as a marker of it being a high output. But you will also see the problems and the complications of a high output stoma at volumes less than that. So you may have somebody that is producing sort of 1,600 mils a day that actually is still running into problems, getting readmitted with dehydration or needing support in terms of medication or given an oral rehydration solution to take. We also see though that surgeons will say, oh, you can't be discharged home until your output's less than a litre. Again, you have to really think about if that's practical, because it will depend on how soon it is since that stoma was first made, and it also might you have to consider other things such as the positioning of the stoma as well. So actually, in some ways, it's not about the volume that's coming out per day. It's more about what volume can be causing problems. So problems such as dehydration or electrolyte abnormalities. We've got an example of we used to have to manage a young girl with Crohn's disease, and on paper she didn't have a high output, but actually we ended up, the only way we could manage her electrolyte balance was discharging her home on 9 litres of saline a week. So again, it just shows you that sometimes it's not just about the amount that's coming out every day. Okay, looking at the literature though, definitions. Again, I've said it could be more than 2 litres per 24 hours. Again, it depends on intestinal balance, so that's what's going in versus what's coming out. We did a study in Leicester back in 2011, and we looked at anyone that was referred to our team with a high output stoma. And it was stomas that were formed during that hospital admission. And we found, using our definition of more than 2 litres per 24 hours for 3 consecutive days, we found that affected about 16% of newly formed stomas. The other thing that's of interest now is the readmission rates. So we are seeing a cohort of patients where they have stoma surgery, they go home, but actually they get readmitted with problems such as dehydration or acute kidney injury, and that's because of the volume that their stoma is producing. Okay, so going on then to look in a little bit more detail about what we found when we did our survey, we looked at the causes of a high output stoma. So we found about 20% of the patients that referred to us had a short bowel, so they had less than 200 centimetres of small bowel proximal to their stoma. We also saw there were other reasons why someone might get a high output. So we had some patients that had sepsis, so that might mean that they had a intra-abdominal collection. It may be someone that actually was having obstruction. So what you can find with someone that's getting a high output is that basically their bowel is obstructing, and these people will often report that they get quite bloated, they get gripey abdominal pain. And what happens when the bowel obstructs is the body tries to cope with it, it tries to flush it through. So what happens is the bowel obstructs, fluid moves from the plasma into the bowel lumen, and you get this gripey pain, and that's the peristalsis, the muscles trying to move the blockage along. And then what often happens is people will often say that their stoma output reduces or stops as the obstruction relieves itself. Then they get a high output because all that fluid that's sat in the bowel then comes out into the stoma. So it is often worth trying to establish if they are getting those sort of symptoms. And we can manage that quite successfully with a low fibre diet in terms of trying to stop those sort of intermittent blockages occurring. You can see a problem with medication that can cause a high output. So, for example, it's quite common if somebody has to go to intensive care that we will give them medication such as prokinetics to help them with their gut function and absorption of things like nasogastric feeds. So they may be put on things like metoclopramide or erythromycin. If that's not then stopped, that can cause problems because it's just going to increase the transit time and get things flowing through the bowel more quickly. You can have a problem that if you very suddenly stop steroids, it can cause a problem, or things like antibiotics may also increase stoma output. You may have a problem with infection, so things like C. diff obviously would cause a high output. It may be pre-existing disease, so are they having a flare-up of their inflammatory bowel disease? The really key thing to note though is actually we found that in just under half of the patients that referred to us for a high output, we could find no cause for why it was happening, and it was just a transient post-op thing that happened, and they settled down. They settled down within 1 to 2 weeks after surgery. We do also see people presenting with a high output late. So they may have had a stoma, gone home for quite a period of time, and then suddenly these problems start occurring. Again, it might be because of that intermittent obstruction that I've just described, or it may be things like a stenosis at the stoma site, exacerbation of pre-existing disease, so again a flare-up of inflammatory bowel disease or reoccurrence of cancer. Medication, so in this group it might be things like chemotherapy that can affect particularly things like electrolyte balance. It may just be that actually this patient was given medication to help control output, so they might have been put on things like codeine phosphate for output or even for pain, or things like loperamide. They go home and that gets abruptly stopped because the prescription doesn't continue, and then suddenly we'd find them running into problems. It may also be compliance, so it might be that they are somebody that does need to have additional fluid and electrolytes in terms of things like an oral rehydration solution. They stop taking it, or they start drinking a lot more hypertonic fluids, and then they run into problems, and that causes them to get readmitted with something like dehydration or sodium depletion. Okay, this table then gives a bit more of an indication of when we would see problems arise, and this is really around sort of fluid and electrolyte balance. So if you start at the bottom here, majority of people hopefully will manage fine on normal diet and fluids, and they're just having a little bit more fluid and additional salt. When we see the output going up in terms of the daily volume, that's when we see we need to put in additional measures. So, for example, we may have to start thinking about an oral glucose electrolyte solution or oral rehydration solution. For some people, though, if their output is very high, so for example, more than 3 litres a day, then we are more likely to have to think about intravenous support. And that might just be things like intravenous fluid and electrolytes, so saline and magnesium, or it might be that they actually need parenteral nutrition. Okay. In terms of treatment then, you first need to confirm that the output is high. But that's often easier said than done. So on busy surgical wards, we don't always get an accurate 24-hour fluid balance. For those of you that work in the community, again, it's not always that easy in terms of actually getting a measurement of what their daily stoma volume is. So you sometimes have to be a bit of a detective, don't you? And it might be that you have to ask questions like, how many times are they emptying the bag? Are they getting up frequently at night? I would say there's a word of caution there, though. I've been in clinic before with some of the doctors, and they've turned around and just said, how many times you're emptying your stoma? We all know that some people choose to empty their stoma when it's not very full. So just saying I've emptied my stoma 10 times doesn't necessarily mean that that is a high volume. You can also ask other questions like, have you suddenly noticed a change in consistency? Has your output become a lot more watery? Is it more biley green colour? Because that, again, that can be a sign there's going to be a problem with a high output. So in terms of treatment, we have to reduce the amount that's coming out. So that's when medication would be used. But also we can reduce the output by reducing how much is going in. So we can restrict fluids, how much someone is drinking, and we can also restrict how much they are eating. The trouble is then you've also got to think about how are you going to replace that, because you can't leave somebody not drinking enough and not eating enough, because then you're going to run into problems with dehydration and malabsorption. You have to adequately replace fluid and electrolytes. So you have to give rehydrate intravenously and then think about the types of fluids you're giving. So as I've said, the key thing is to try and reduce intake. We know that stoma output is driven by fluid and dietary intake. That's why a stoma functions more in the day than it does at night. But we also need to bear in mind that the other thing that can affect output is obviously all those gastrointestinal secretions. So, you know, your saliva, gastric acid, pancreatic biliary secretions that go into the bowel every day that are normally reabsorbed. But if you've got somebody that has either a short length of gut, so a jejunostomy, or you have someone where their gut is not functioning very well in terms of absorption, they're not reabsorbing it, and that's why it's coming out into the stoma. And I've mentioned, obviously, you need to think about how you are going to meet someone's hydration and nutritional needs if you are reducing the intake. Okay, in terms of replacement then, acutely you would give someone intravenous fluids in the hospital setting, or it may be if they're having nutritional support, something like parenteral nutrition, you would also ensure that that has adequate amount of fluid but also of electrolytes, so adequate amounts of sodium. You would then try and wean them off intravenous fluids onto an oral rehydration solution. And the key thing here is that it has to have an adequate amount of sodium in it. So you're aiming for a solution that's got between 90 and 120 millimoles of sodium per litre. And you also need to be thinking about the osmolarity of that solution. So something that's very concentrated and hyperosmotic is also going to drive a stoma output. You also need to limit ongoing losses. So as well as giving someone an oral rehydration solution to drink, you also need to reduce the amount of other fluids they're taking. So we would often say someone can start on 1 litre of St Mark's, because that's the oral rehydration solution we use as first line. And then we would cut down their other fluids normally to start with to 500 mils. Some people can get away with having it up to 1 litre. We do sometimes have to put people nil by mouth. We would do this if we are finding that we just can't get on top of an output that's very excessive. So maybe if their daily stoma volume is sort of more than 3 litres. The benefit of putting someone nil by mouth for 24 to 48 hours is you should see the stoma output come right down. If it doesn't, then what's driving that stoma output is secretion of gastrointestinal secretions, basically, and that might then indicate that there's something else going on, particularly things like sepsis. If you do find that their output comes down, it's then a time to reevaluate. One, it helps the patient actually sort of understand that it is what they eat and drink that drives their stoma, and that's why compliance is important. And it also allows you to reintroduce things in a more stepwise fashion in terms of building them back up. Some of the difficulties with management of a high output stoma is everything gets thrown at the patient at once. So suddenly they're on a very high dose of loperamide, they're on oral rehydration solution, they're also on saline, and it can get really quite muddled. And it's actually helpful sometimes to have a bit more of a stepwise way of managing them. Okay, so let's look at the options for oral rehydration solutions. The one that's probably most commonly used is something called St. Mark's solution. This is actually modified WHO cholera solution. So WHO cholera solution also has potassium in it, so St. Mark's, it's been modified. So it just contains sodium, obviously contains glucose, because you need glucose to help with absorption of sodium. And it's normally, the patient's normally given instructions to measure out teaspoons or half teaspoons and make it up in a litre of fluid. Alison Colkin, who's a dietitian at St. Mark's, did do a study though and showed on hospital wards there's a huge variability in the concentration when it's made up. I can't imagine what it tastes like if it's got a concentration of 224 millimoles per litre. You also have to be careful with what's being added to it in terms of if you're adding squash, because you're not only increasing the volume, which is diluting the sodium concentration, it can also affect the osmolarity. The key thing we encourage people to do is make sure that the total volume goes up to a litre, so you don't make it up to a litre with just the water and then you add the squash on top. Okay. I did cover this in the other section that I delivered when we looked at dietary recommendations, and we talked a bit about sodium and fluid absorption in the bowel. But it's worth reminding ourselves how oral rehydration solutions work. So if you've got someone that's got a high output stoma and you give them lots of fluids to drink that don't have salt in, so that's just, general drinks, tea, water, squash, what happens is that fluid goes into the bowel lumen, and then you've got a lower concentration of sodium in the bowel lumen than you actually have in the blood plasma. So what happens is that sodium moves from the blood plasma into the gut lumen to try and redress the balance, and as the sodium moves, the water moves with it. Normally, it would travel down into the bowel and get reabsorbed, but someone that's got a high volume stoma is that fluid is then lost, that fluid and sodium is then lost into the stoma. And that's how patients can get dehydrated and salt depleted. The difference is if you give a fluid that has a higher sodium concentration, so more than 90 millimoles per litre, when that travels into the gut lumen, it's a similar concentration to what's in the blood plasma, so you don't get such a shift, you don't draw the fluid and the sodium from the blood plasma into the gut. So less fluid's travelled over, so that results in a lower stoma output. The other thing we find then is because the patient isn't becoming dehydrated and salt depleted, they haven't got that constant urge to then try and drink more. And you can often, what you find with normal fluids is you just get in a vicious cycle. They become very thirsty, they drink more, they become more thirsty. So using an oral rehydration solution helps break that. Okay. There are other options available for oral rehydration solutions. So another one that's quite commonly used is Diarrhealite. You do need to bear in mind that the sodium concentration when it's made up as recommended is 1 sachet per 200 mils of water, and that only gives a sodium concentration of 60 millimoles per litre. So a lot of places either suggest it's used as double strength, so that's 10 sachets in a litre of water, or you might do something like give 2 sachets in 300 mils of water. You do need to bear in mind though that it does contain potassium. So if you're giving 10 sachets a day, you're giving 40 millimoles of potassium, which may be a problem in some patients. And you also need to consider the cost, particularly if it's being prescribed in the community. There has been some work done though to look at other options. Some people have looked at whether we can use solutions that are naturally high in sodium, so things like soup, or things like beef extract, like OXO cubes, that sort of thing. Obviously, bear in mind that they might not have the right glucose concentration that is also required in terms of absorption. You can add salt to normal fluids, and bear in mind that 1 gram, so one of those little sachets of table salt, is the equivalent of 17 millimoles of sodium. So one of the recommendations is that you can sort of do a home brew, really. You can use tap water with squash and add some salt to it. We often get asked about things like isotonic sports drinks and whether they're suitable. They do have some sodium in them, but the problem is they don't have a high enough sodium concentration to use them in replace of something like St. Mark's solution. So Lucozade Sport, for example, only has between 16 and 20 millimoles of sodium per litre. So you can see that it's a lot less than the 90 millimoles per litre we're recommending. I would mention though, or I'd like to mention that as well as managing those that have a recognised high output stoma, there's quite a lot of interest in whether giving generally people that have had a stoma formed and they've just gone home from hospital, whether giving them something that's got more sodium in it can actually help in terms of reducing readmission rates for dehydration. So this was a study that was conducted a few years ago now, and they looked actually at sending home everybody. Well, they had 2 groups. They had the intervention group where everybody, irrespective of stoma volume, was sent home being encouraged to drink an oral rehydration solution every day, versus a control group where they weren't given it. It's interesting because in this study, no patient had a stoma output of more than 1,200 mils per day. So none of these patients would have been classified as having a high output. But actually, they did find that they had a significant reduction in readmission rates, and also their blood profile in terms of looking at their sodium levels and their kidney function was better. So there probably is a place then for actually giving patients more sodium, particularly in that initial period, sort of the first 6 to 8 weeks after surgery before their stoma adapts. Okay, we often get asked about other electrolytes, and the one thing that we concern ourselves about is magnesium. Only a third of daily magnesium intake is actually absorbed, and absorption occurs mainly in the distal small bowel and the colon. So you can already see why those people that have a small bowel stoma, particularly one that's maybe quite high up in the bowel, are going to run into problems with magnesium. Obviously, bowel resections reduce the absorptive area. And the other thing we see is that if someone is becoming salt depleted, what happens, the body's quite clever. So if you're losing a lot of sodium through a stoma, the kidneys will try and conserve the sodium. So they do that, though, at the expense of losses, renal losses of other electrolytes, in particular potassium and magnesium. So actually, sometimes part of the management of someone that's got low magnesium levels is to make sure that they are getting adequate replacement of sodium. So if they're sodium depleted, you must give them the saline or the sodium to replace that, and that should help the magnesium levels. You can give oral magnesium supplements. The difficulty is that they can, as a side effect, cause diarrhea. So the last thing you want to be doing is giving magnesium and then causing the stoma output to increase. We would often give oral supplements at night when stoma function is more reduced than it would be in the day. Some patients do actually end up having to go on to some sort of intravenous supplement, and that would be managed under a sort of specialist team. Okay, I just want to mention a couple of myths because we do often find situations where we have somebody that has a high volume coming out of their stoma. They're put on an oral rehydration solution, but the doctors say, well, actually, they can drink as much of that as they want because it won't affect their stoma function. Or they sometimes get told they should match their losses from their stoma by drinking more of their oral rehydration solution. And that's really not good advice. So let's go back to the original research then. So this is the study that was done by Jeremy Nightingale. He took 6 subjects and they all had proximal bowel lengths of between 105 and 250 centimetres to stoma. And he compared giving them a litre of water, a litre of an oral rehydration solution, a litre of water with salt capsules, and then a modified oral rehydration solution. And actually, if you look at this, and this is the data of the subjects, the stoma volume didn't significantly decrease. So if you replace a litre of water with a litre of St. Mark's solution, you're not going to dramatically see a difference in their stoma output. But what you do see is a significant difference in sodium balance, and the sodium balance improves. So this goes back to my point that I made earlier then. It's about, if you correct their sodium balance, it often then stops them wanting to drink so much, so they're not losing a lot through their stoma. So really, you have to use an oral rehydration solution in conjunction with a hypertonic fluid restriction. And there is no point giving excessive amounts of it because it will still drive a stoma output. So what we generally find is if you still can't maintain someone's sodium balance and they're drinking up to 2 litres a day of something like St. Mark's, there's no real benefit in telling them to drink more. That's probably the stage where you'd have to think about maybe giving something like intravenous support. And it's really important that you look about compliance to how much other fluid they're drinking. Okay. The other thing we often get asked is how we improve compliance. We get comments like, oh, they all taste revolting, they're very salty, we can't get people to drink them. So just in terms of how to improve compliance, sometimes you need to think about timing, because in some ways people have to be slightly salt depleted to be able to drink them. If you've got somebody that's having their sodium adequately replaced by, for example, they're having intravenous saline, intravenous fluids, then it's going to be quite difficult for them to drink it. So sometimes it is a case of, like you say, this needs to be slightly sodium depleted so they can manage it. It's important to think about practical things like temperature. It does taste much better if it's cold. That can be actually quite difficult to manage on a busy surgical ward. Often what we find happens is that the litre of fluid, St. Mark's solution, gets made up in the day and just left on the bed table. It is much better if at home they can put it in a bottle and store it in the fridge. Make sure you give it a stir or a shake, so you're not finding that all the sodium is gone to the bottom. But do try more than one type. St. Mark's can be made up with sodium citrate rather than sodium bicarb if you can get it from your pharmacy, and that sometimes improves the taste. Think about what you're adding to it. So sometimes flavourings such that are quite tart, so things like lime cordial or something like grapefruit makes them easier to manage than adding a squash that's maybe like orange or blackcurrant. Or try the home brews. If really St. Mark's isn't working, we use St. Mark's as first line. We possibly would consider Diarrhealite as second line. If we're still really struggling, then we maybe would consider some sort of home brew to see if that's going to work. The key thing is patient education. I think if they understand the reason why they need to take it, then that often helps. The difficulty we do have, though, is that often they're given the wrong advice from other healthcare professionals. I'm sure we've all come across stoma patients that have been readmitted dehydrated. And the first thing they're told is to just drink more fluid and go home. And actually, unless you're giving them adequate sodium, you're just going to run into more problems. Okay. So monitoring then, it's really important that these patients pass adequate amounts of urine. So we do need to be making sure they are passing, ideally 1 ml per kilo per hour or 25 mils per kilo per day. If you've got somebody that's running with a urine output of less than 800 mils a day, that's when they're at risk of renal complications, and it might be that they need intravenous support to help with that. We do suggest that you check someone's random urine sodium, because if their random urine sodium is less than 20 millimoles per litre, that is a sign they're getting salt depleted. They're losing so much sodium through their stoma that their kidneys are trying to conserve it, and that's what we're seeing. Also, that is a more sensitive marker of sodium status than just looking at someone's blood levels. Okay. Really, you should have local management guidelines. They may be based on national guidelines, but whether you work in the acute trust setting or you work in the community, you should have management guidelines for high output stomas. When we did our study back in sort of 2010, 2010, 2011. As I said before, we classified a high output stoma of more than 2 litres per day. We have found now actually that we've reviewed our stoma guidance and we have guidelines on how to manage an output that's between 1200 and 1800 mils a day, and then we have more guidance on how to manage an output that's more than 2 litres a day. And that's partly because we were finding patients that maybe were producing sort of 1600 mils a day, everything was getting thrown at them. The doctors were prescribing high dose loperamide, codeine, they're on WHO solution. It was getting quite complicated. So I think the key thing with any guideline is it has sort of a plan and it has a way of reviewing. So that's what our guideline shows. You need to think about who's responsible, one for initiating it, but also maybe stopping it. So that group of patients where actually they may have a transient high output stoma that reduces, they need to also then try and make sure that you're weaning them off things like high dose loperamide once things start settling down. The other thing you need to consider is how you can access more specialist advice. So we, for example, now with our colorectal nurse specialists, we have a way that they can get patients admitted to our surgical assessment unit. It's much more appropriate that they go there than they actually go to a medical assessment unit, where they're more likely just to be given some saline and told to drink more and go home. So particularly if you work in the community, make sure you've got some sort of pathway or plan to how you can access specialist advice or get patients readmitted, or if you're doing things like monitoring bloods or asking GP to monitor bloods, you've got a plan in place to what to do if they're abnormal. Okay, that just shows you the other guideline that we have then for those that are having more problems with high output stoma. There are also community guidelines available, so I've put the national guidelines on here, which are really useful. They're also useful because they give us a suggestion about how you can assess dehydration. It's sometimes not all about just trying to get a blood test, it's about asking the patient if they've got any markers that would indicate they might be getting dehydrated. So looking at what their urine output's like, are they weighing themselves daily and finding a rapid reduction in body weight? Are they feeling dizzy, particularly when they're going from sitting to standing? Are they getting cramps? That might indicate they've got particularly a problem with their magnesium. So it's really important that you do that sort of global review of a patient when you're seeing them. Okay, so in summary then, this section is really focused on fluid and electrolyte management of high output stomas. It's really important that you assess a patient and you use sort of evidence-based guidelines to help manage this patient group. As with all stomas, we do find that sort of dietary concerns are there, and we need to make sure that we are giving consistent advice, and I covered that in the first section. And also, I think you need to be able to seek specialist advice where possible, and you have to have guidelines for when you seek that specialist advice. So that ends my talk for today. Thank you for listening, and I hope you found that useful.
Hearing from Melanie is so interesting, and hopefully she has provided us all with, excuse the pun, food for thought, and that this session can be a catalyst to encourage us all to reflect on the advice and care that we offer to patients experiencing a high output stoma. Thank you for watching this episode. I do hope you've enjoyed it. If anyone has any follow-up questions, then please do email us at discover@salts.co.uk. This episode, along with all the other sessions as part of the Discover series, can be viewed on demand at the Salts Healthcare website. So please do feel free to pause and replay at your convenience, giving you the time to write notes and reflect on the session. Please click on the link at the end of the episode or from the main Discover series page on the Salts Healthcare website to access the evaluation form. On completion of this evaluation form, you will be redirected to a page enabling you to print out your certificate of attendance. The third and final session within this Discover Series 4 will be launched on Thursday, the 14th of April. In this episode, we will explore the pharmaceutical management of a high output stoma.